Thank you. Today is the 1044th day of uninterrupted daily webinar of Ifph. Before beginning the session, let's have a silent prayer. Hello, doctors, students of homeopathy, and homeopathic friends. Today is the 1044th day of the uninterrupted daily webinar of International Forum for Promoting Homeopathy. And today, our guest is Dr.Shubhajith Banerji. Dr. Shubhajith Banerji is presently one of the spotlight physicians in the domain of homeopathic health care services in Kolkata. Dr. Banerji's yardstick of curability rests on prevention, treatment, lifestyle management. Specializing in peptic ulcer syndrome, he has been recognized as a certified physician on medical management for lifestyle-related diseases by the Harvard University, USA. Professionally trained physician in allergies by World Allergy Organization, USA. His academic and deep-root interest in diverse field of healthcare earned him diploma in dietetics and therapeutic nutrition, and also achieved postgraduate diploma in biomedical informatics from Biomedical Institute of India. Dr. Shubhajith Banerji has accomplished commendable heights in multi-level health services, ranging from undertaking training on lifestyle diseases under Harvard Medical School, USA. He has long-term intensive clinical training in government hospitals, workshops on HIV and AIDS preventive cardiac care and cancer. Dr. Shubhajith owns a professional experience of clinical practice in homeopathy and nutrition for 19 plus years, with expertise in academic arena as homeopathic lecturer and clinical tutor in Parallel University, Gujarat. Also empaneled as visiting faculty in healthcare management for government officials with Netaji Subhash Administrative Training Institute, Government of West Bengal. His passion to serve for human life kept a bold mark, wherein he worked as OPD in charge and visiting consultant at Sainath Homeopathic Hospital, Baroda, Gujarat. In the homeopathic hemisphere, Dr. Banerji's treatment belt on is tied with three codes, that is concern, cure, and care. And the subject for the day is Alarm for Allergy. Let us welcome Dr. Shubhajith Banerji for the session. I welcome you all for the session.
Kindly making co-host, please make Shubhajith.
Am I audible?
Yes.
Okay. Good evening, everyone. All the introductions already been given by Dr. Binduraj. I am grateful and thankful to the associations and Dr. Dinesh and all of you to give me the opportunity today's evening. Now I just want to share my screen. Okay. Hopefully this screen is visible.
Yeah, it's visible.
Okay.
Let's start. Thank you.
Now this nomenclature of the title is very significant, because last week of June, our association, World Allergic Organization, has observed World Allergy Week. So it is a consequence of that. So we can discuss the thing and we can learn from each other for our daily practice. Now, before going to into these detailed slides, I just want to give some disclaimer. Whatever the informations, the slides, the pictures, as well as captions from different articles, they are collected from internet. As much as possible, the authenticity has been taken care of. If there is any difference of thoughts or different of opinions, that has to be there, because that's and through which we can learn the subject. Now, why it is alarming and for this allergy? Because allergy in our daily practice is very common phenomenon and numerous of patients we can get or we used to get on these subjects. Now, why it is alarming? While we'll go through these slides, we will make ourselves updated why it becomes alarming. Next. Now, as we are all are the clinicians, so let's start with the subjects or the sign and symptoms which we can face in our day-to-day practice. How the patient will represent themselves in front of us. That's why I am starting these slides or my presentations with the presenting complaint of. Very common symptom, a very common sign. Yes. So all of us are very used to get these type of signs in our clinics. Now, is this an allergy or is this something else? So let's start what WHO has guided us. In their last meeting, minute of the meeting with World Allergic Organizations in 2002, allergy is a hypersensitive reactions initiated by immunological mechanism. All these points or all these words are very sensitive. And I just request all of you to give a note of it and give emphasis on this part. This is hypersensitivity and immunological mechanism. Why? Because we used to get a word that is atopy. Now, what is atopy? How it is related with allergy? Atopy is personal and or familial tendency. Just try to give emphasis on these parts. Usually in the childhood and the adolescents become sensitized and produce IgE antibodies in response to the ordinary exposure to low doses of allergens. Now, there are 3 points. One is personal and familial tendency. Second is IgE antibodies and low doses of allergens. Why? These consequence of topic that atopic individuals develop multiple of typical symptoms which we used to get. That is allergic asthma, rhinitis, conjunctivitis, and any other dermatitis. But you just try to mind all these symptoms or the diagnosis are prefixed by an word that is called allergic. Why? We will see in our next slides. Now, this is the Harrison, how he defined in that book, edition 20th, that atopy implies the tendency of manifest asthma, rhinitis, urticaria, and atopic dermatitis alone or in combinations. Dear doctors, please give emphasis on this. Asthma, rhinitis, urticaria, atopic dermatitis alone or in combinations in association with presence of allergen-specific IgE. So all these symptoms, all the diagnosis may come alone or in together with each other. Now, these are hypersensitive or hypersensitivity, which we have, the WHO had guided us. There are 4 types of hypersensitivity reactions that till date it has been found. 1, 2, 3, and 4. There are so many subtypes into it. I am not going into detail, but there are 2 points which have been highlighted. That is, one is allergic rhinitis in type 1, and same allergic rhinitis in 4B specifically. But as our next slides will be on these topic only, I am emphasizing and highlighting these points. Now, why I am highlighting? Because type 1 is the mast cell mediated, which is IgE dependent. Now, just below to that, there are Ig independent as well. Number 4, that is the persistent asthma and allergic rhinitis. That means this is the acute manifestations or acute presentation of the allergic rhinitis, and if it becomes chronic or the persistent or recurrent, that is recurrent persistent asthma and allergy, which comes under 4B. Now, these hypersensitivity and the allergies are of many types, many manifestations that affects many or multiple systems in our body. So I am in today's topic, I am trying to concentrating myself in allergic rhinitis only, because what I feel, this is the most common received symptoms or the patient in our day-to-day clinical practice. There are, you can heard of gluten allergy, that is affected the GI and chiefly from GI, and that can spread in other words. So that may be another topic. Because of the percentage of number of cases, I am starting with this hypersensitivity and the allergy with allergic rhinitis only. So our discussion will be concentrated only on this topic. Now, allergic rhinitis is an inflammatory nasal mucosal mediated by IgE associated processes occurring independently or concurrently with asthma. Dear doctors, seniors and juniors and our colleagues, this is I just want to identify. Now, Ig mediated immune response that against the inhale antigen, immediate phase and subsequent leukotriene mediated, that we will discuss later on. Now, why it is alarming? Kids between 6 to 7 years and adolescent kids are at the maximum percentage of industrial world, increasing day by day. Nearly 2 million lost school days, 6 million lost work days, and 28 million restricted work days per year. Now, just it is a US data, obviously. They have quantified these small allergies, that running of nose and whatever the signs we have already given in the picture, that reflected in a multifold in our socio-economical status. Further, it is a very emphasizing, it is, I am just trying to concentrate on this, sorry. Seasonal allergic rhinitis seems to be more common in pediatric age group. We used to get this. Family history of atopy, male sex, and allergen-specific IgE. All these before age group and higher socioeconomic status are the key factors. Pollutions and environment of allergic rhinitis, the link between it is not so yet to be exist. I think some of you can differ why it is so, because these non-Ig mediated hypersensitivity is also does exist. That means rhinitis may or may not be IgE mediated or Ig related, but both of them come under rhinitis. That may or may not be allergic. I am trying to emphasize because we have started our discussions with the WHO definitions. That is, it is IgE mediated. That's why on those categories, they are only called allergic. But there are some other category which are non-allergic rhinitis as well. Now, this is the pediatric prevalence, because we used to get pediatric cases in our clinics who are suffering from this rhinitis. Now, these flowchart already been given by Allergy and Asthma Immunology Research Center, and this data is collected from China. Why? Why it is very important? Because our next slides will be depending on this. Prenatal events. The child is yet to born or come into the world, he or she is susceptible to these kind of allergic reactions. Why? Because child postpartum delivery of his or her mother, no siblings, cesarean sections, these are all the China data. Post-natal events are also there. Now, environmental factors is also there. Now, this is the another factor, that is genetic susceptibility. Now, these genes are also the factors of getting allergic rhinitis in our next generations. Now, what is the pathophysiology and why we are emphasizing so much on IgE? This is the flowchart, very simplified. There are so many intricacies in between. I am not going into this, because will be concentrating on the clinical part than on the theory part, because all of us are clinicians. Now, allergens, which comes into that crosses the epithelial cells, then it goes and affected the mast cells, which release the histamine. Now, these histamine will be the key role for these further reactions. Now, for primary phase, this early phase, we used to get these kind of symptoms, that mucus, production of mucus, runny nose, who is little bit itchy and red eyes, nasal itching and sneezing. Now, on the later half, it becomes nasal congestions, mucosal inflammations, and runny nose. Because of the change of this little bit of symptoms is due to the pathophysiology is going as undercurrent in these type of reactions. Now, these leukotrienes, which is released in the phase 1, that will affect in our later phase. And these histamine will give us the vasodilatations, smooth muscle constrictions, and all these things, and which will give subsequent symptoms of these kind of symptoms in first or latter half in the phase of disease. Now, taking history is very important in our pathy, or rather in any pathy. History taking is very important, and we used to teach in our university level at undergraduate. So, what are the symptoms we used to get to diagnose the case clinically, or at least we can think of what would be our plan of actions. Now, types of the symptoms, time and durations. What are the types? How the patient is suffering from it, the time, in which part of the year, any seasonal affections, and the durations. Maybe in the morning, early in the morning, I think you may agree, more than 80% of these allergic rhinitis patients used to have these kind of problems once they get up in the morning. And that may or may not last more than 2 hours in the day. And that will ruin his or her daily activity. Because it is early morning, if he or she get this kind of thing, runny nose, itching in nostrils, then multiples in number of sneezing, how that person will work, how that person will go to school, how the person will go to his clinic. That's why the time is very important, and that's why it is alarming. Frequency of the symptom, suspected exposures, and seasonality, which I have already discussed. Exacerbations and elevation factor. I have that allergic tendency, but I could not find what are the things which can triggers this kind of factors. Now, post-nasal dripping, chronic nasal congestions, obstruction in throat and chest and nose. This is very common symptoms. Now, family history of allergic rhinitis or a personal history of asthma is the triggering factor. So these 5 points are very important to while we to discuss with the patient while we are taking the history. So it is my earnest request to my learned colleagues, please take care of these 5 questions with you for the any type of allergic related or rhinitis related history taking. If it is no, out of 4 questions will be no, 88% or rather 90% of chance of negative of skin prick test. Now, what is skin prick test? We will discuss in our latter half. Now, then what I am supposed to do? We have to have 4 more questions. That is, do you have any kind of hay fever kind of thing? Does your parents having this kind of thing? Does your brothers or sister is having this kind of thing? Hay fevers. Allergic symptoms are vary from one person to another and from place to place. Very surprising. The person who is suffering from allergy on daily basis, in 90% of the year or in a month, in Calcutta, when they go to Uti, when they go to Darjeeling, when they go to high hills, they don't have this kind of problem. But why? So there must be something which triggers. Is there any specific triggers that we have to collect? So accordingly, we can plan our diagnosis, treatment, and ultimately the medicines. Again, as we are clinicians, we have to have these kind of signs in our clinic. I would request my colleagues, please give emphasis on these pictures at least. Allergic shinners. This is the thing. Very common in our daily practice for allergic patients. Allergic conjunctivitis, this kind of thing. Now you can see this runny nose. Allergic salute, this is the thing. Why I am giving this kind of photographs? Because I do feel these photographs will give more impact and give you more informations rather going for a descriptive type of things. So allergic salute is this kind of posture patient or the kid used to give in front of you at your clinic. Now this is the allergic phase. This is the crease. You can find a very faint crease due to these postures in our daily practice. Now, these are the physical examinations of the patient. Henceforth, please take care of these kind of symptoms at your clinic so you can find or you can have an idea at least whether it will go to some allergic rhinitis thing or anything related to allergy. Now, if this is the common sign, this is very common. This is the pale and bluish hue or the pallor along the terminus of the edema. This is the nasal edema. This is very common what I do feel because I am concentrating on my practice or in allergic patients. So these club stoning is nowadays, after learning what is club stoning, I should be fair enough to disclose my scenario, because earlier I didn't know. But now, once I know what is club stoning, I used to find, is there any club stoning? Club stoning is what I should say. It is a small cyst kind of thing. It is a palate. Now it is the lower part and upper esophagus part, and this is the uvula. You can see these, in this area you can find these club stoning. So it is the posterior pharynx, and you can easily find out. It is very easy to identify by a single torch light. Now these allergic rhinitis is connected with eustachian tube dysfunctions, because patient may or may not present with the blockage of ears, heaviness in eardrums, or any discharge. So anything, because of these eustachian tube dysfunctions, we can have the accumulation of fluid from here to there. So that is what I should say, accumulated or the accompanied with this rhinitis thing. Now these are all clinicals which we have already discussed. These are the clinical findings and clinical sign and symptoms we used to get in our daily practice. Now we have to establish the diagnosis or as documentary evidence. As we have started our discussions as per the WHO guideline, IG is the key factor for differentiating allergic and non-allergic rhinitis. This IgE level in blood or the serum, we have to give a very common symptoms or very common, diagnosis we have to give or ask patient to do so. With serum, because I used to give these blood tests along with the vitamin D. Vitamin D has its own role for these allergic kind of things, that is a immunity. Absolute eosinophil count, that you can already understand. This is the type of lymphocytes, and the eosinophil is one of the soldiers, type of soldier that can give a first level of efforts or the protections. Then IPO, that Hashimoto thyroiditis, or that can consider to be T helper cells. The T helper cells that acts on the mast cells, and which in turn release histamine and the leukotriene, which can give you, we have already discussed, which can give us the symptoms at early phase as well as the best phase. Obviously, this histamine, I have already mentioned, this histamine and leukotriene are the key factors for this immunity and to process the immunofunctional activities. Now, this skin prick test, I think many of us, or rather all of us, are well aware of. This is the skin, very authentic and orthodox and one of the dependable investigations in the field of allergy even today. Though there are some different of thoughts and different that acceptability to the patients, as well as is its what I should say, cosmetic value. These skin prick test nowadays in a back foot, but it is one of the most authentic tests, can give you specific results. Now these radio allergy sorbent test, it is the nowadays that blood we used to take the samples, and from there we can go these allergies, different type of allergen, and we can find the sensitivity of the patient in a particular allergen, one or more. Nowadays, that immunocap Isaac is another test. It is high profile test. It is a modified version of RAST only, And Fediatop is another commercialized but very sensitive taste that you can easily find in internet, YouTube, what is the benefits, what is the drawbacks, and how sensitive they are, and how give the specific results of the particular person who is sensitive to that particular allergen. Why I am telling this molecular allergology, it is yet to be commercialized or available in the market because of its approval. It is not yet approved by FDA. Now, issue is, as you know, or all of us, we know that some kids nowadays, they are sensitive to milk. They used to get milk allergy kind of thing. They cannot digest. Now, is the whole milk is enemy for him? No, sirs. It is not so. As we know, it is lactose. Maximum of milk intolerant kids are sensitive to lactose. That's why they are specified. These kind of allergy is the lactose intolerance. And you may find there are so many artificial food items or artificial, what I should say, pediatric food items. They are lactose free. So that means whole of the milk is not intolerant by the kid. Only the lactose part is the allergen for him, who is sensitized or who is very sensitive to that lactose. This is molecular allergology that will give you the differentiating part, which are the molecules of a compound or of a food or of a protein or of a common allergens is the person is sensitive to. So they will give the particular molecular level. So that's why it is very, very educationally, it is very good. But as it is commercialized, not yet to be commercialized, so I can say its result and benefits of it. Now, DD. It is, I feel it is very important in our practice because we have started. There are two types of rhinitis. One is allergic, another is non-allergic. Now, rhinitis means running of nose. Very common and very, what I should say, very commonly colloquial language, it is running of nose. Now that running or the fluid, where from it is coming, whether it is a vasomotor rhinitis, it is a non-inflammatory thing, triggered by temperature, some perfumes, some odors, some humidity. Even many of us had already experienced when we have the chili, green chili we bite, we used to get the rhinitis. So is it an allergic or is it a non-allergic? It is actually a vasomotor rhinitis. So it is rhinitis, but it is neither allergic nor non-allergic. Now, infectious rhinitis, viral and bacterial infections are also there, very common in pediatric age group. Now, this is the thing where colleagues, cerebrospinal fluid leak. I think day before yesterday, when Dr. Partha Chakraborty sir has given some, he presented this kind of, one of his glioma case. One question could already cropped up. One of these colleagues, his wife is having this kind of runny nose with leakage of CSF. So this is that is also leakage, and that is through the nose only, but it is neither rhinitis, allergic kind of or non-allergic kind of. We have to find out whether this is, what is that. Now, non-allergic eosinophilia, that is also because it may not or may not be, that is without allergic sensitizations that we have already discussed. Now, chemical rhinitis, we have already experienced in our chemical physiology lab or our chemistry lab in our school days and college days, and there are so many chemicals which can give us this kind of rhinitis. Rhinitis during pregnancy due to hormonal induced rhinitis, they have already identified. Then vasculitic rhinitis, that is glomerulomatosis and this sarcoidosis disease. Nasal polyp, that can give the patient a rhinitis kind of symptoms, blockage of nose, then running of nose, then also that in cold, if he exposed with the cold air or something, they used to get these running of nose. Then nasopharyngeal neoplasms, then sickle cell anemia, these aeroallergens, they are sensitizations in case of chest symptom of a person or the kid having the sickle cell anemia. It is obviously, it is not my words. This I have collected from British Journal of Hematology. Now complications. I should go a little faster, I feel so. Chronic rhinosinusitis, then nasal congestions with discharge every ongoing for 3 months, nasal polyps already discussed, inflamed eustachian tube dysfunction. This is one of the most important parts, sirs. This is 40% or more than 40% of allergic rhinitis case can turn into asthma in future. Why? That we will discuss. This is my earnest request to the august audience. Please keep it in mind. Maybe it is useful for our daily practice. This is called atopic triad. Starts with allergic rhinitis, go to atopic dermatitis, then asthma. This is triangle, and this is interlinked. So allergic rhinitis, I think all of us has already experienced. The person who is having asthma and presenting the symptom of asthma today, if we can collect the history of his childhood or adolescence or in young age group, we do have this allergic rhinitis, history of allergic rhinitis or any other topic, atopic dermatitis. Now this is called ARIA. ARIA is allergic rhinitis induced asthma. Now these ARIA are of 4 varieties. This is grade 1, grade 2, grade 3, and grade 4. That depends on the severity and the recurrence of the disease or the symptoms. If it is persist, if it is intermittent and less than 4 days a week, that is, it comes mild. There is no normal, disturbing, not normal. So this is the criteria. This is grade 1 to, you can grade it from 1 to 4. Why I have put in this slide, this is what I feel, this is the thing. It has a long-term effect on asthma and give our patient with the asthma. Now it is why it is alarming, because our title of today's topic is alarm for rhinitis, allergy. Now why it is alarming? 20% of the population of United States are suffering from this, potentially threatened because of anaphylaxis. Now severe asthma in later of his life, 6th leading cause for the chronic disease in United States. Please have a note. Atopic march means it is allergic, food allergy, then allergic rhinitis, then asthma. So it is all chain reactions, that is, it is called atopic march. Now gene is the environment, gene and environment, those are interconnected and interlinked, because we have already discussed gene is one of the factors for this. Now this is the classical allopathic treatment protocol. They used to start antihistaminic, then leukotriene, because they have already identified this is the one of the key biochemical factors for this. Then they go for topical corticosteroid, then mast cell stabilizer, then decongestants. Then this is one of the good treatment. Rather, I should not say it is a treatment, it is actually prophylaxis. They used to give the sublingual, that is slit, but now they are giving, or the medical science is giving that is subcutaneous immunotherapy. This is the latest version of that is the vaccination that is already I have said, that is a prophylaxis thing. The patient is what in this process patient get more sensitized artificially, so the natural allergens when is get into in his body, that will not affect. Surgical treatment, if there is any nasal obstructions, chronic sinusitis disease, all this, that nasal surgical cause has to be removed. So this we should keep in, this is their protocol. Now, why it is allergy in case of homeopathic parlance? How we deal? Ultimately, we are homeopaths. At the end of the day, we have all these theoreticals and allopathic treatment. We should keep it in mind in our practice. But why? Ultimate is why. Why? Because ultimately we have to find out the medicines and give our patient at least a relief. At least a relief. And in the long term, we can give some long-term treatment so he or she can come out of this problem of this is hypersensitivity that is already been discussed, inimical dynamic influences, that is all these things already been discussed, sensitivity in our terms already been there in our organelle. So what my attempt is just to correlate the biochemical reactions given by the modern medicines and starting from the Harrison and the organon which is already been written hundreds years back. Now aphorism 116 and 117 we have already gone through in our undergraduate course. These are already been described. Now I just want to highlight one thing: produce no impressions. These are brought in a more and less morbid state by certain things which seems to produce no impressions and no change in many other individuals. So that means that allergens is very common. It is in the atmosphere. But few persons are sensitive to those allergens. That's why this is no impression to others. Now, dear sirs, seniors, and the colleagues, as I have already discussed, and my motto actually is to give the patient at least some relief on day one. At least after visiting my clinic on the very next day, he or she go to his or her work. At least that's why my main motto on the day one is I have to give some palliative or the relief, at least stoppage of sneezing, stoppage of runny nose, at least he can join his normal duty. That's why this is only a indicative therapeutics. All of you can differ with me. That is I will be obliged to learn from you. There are some multiple of options, but this is my thing. Already I have collected and few of them already implemented in my clinics and I got good results. These are the very common that smell, sabadilla, histaminum, solidago, then abrasia. It is very available. Naphthalina is also very good. Very common medicine is Allium cepa. Then Galphemia glutea is another, what I found it is very effective. Why it is effective? I just want to, because it is a plant medicine, I just want to give I have already found out this is the plant. This is all internet source. Nothing, I didn't do any research on it. But what I am trying to give you some highlight, it has an alkaloid that is flavonoid. And this is in genetic, it is inhibit acute bronchitis, bronchial sensitivity, allergic reactions. Dear sirs, madams, and colleagues, please try to give emphasis. The composition of it is the botanical source, but it has some illustrative on it. This is also allergic reactions. They can inhibit. This is the effect. So these are the literature resources I could collect. Again, this is the Phleum Britannicus is also one of the, may not be a common medicine, but it is useful what I found. Trifolium is also there in Boric. It is available in the market, and I found little bit of effective also. And last point is, no, last but not the least, there are lot more of these kind of medicines, and you might have hundreds of other medicines which can enrich me, at least in my clinical practice during your next sessions, or you can carry it forward. Thank you very much for patience listening. Any questions as well?
Thank you, Doctor. You explained in detail about the allergy and the pathophysiology of the allergy and the therapeutic aspects also. And this is the time to interact with the speaker. Participants can raise hands. Dr. Partha Chakravarti. Dr. Partha, please, you can unmute.
Yeah, can you hear me, Dr. Banerji?
Yes, sir.
Okay, it was a very nice presentation.
Thank you,
I
sir.
missed
It is all
those
your
10
blessings.
minutes. I'm very sorry for that. It was a very, very nice presentation. Only one thing I just want to know from you, what is your experience regarding histamine muriaticum, this drug? If you can share your experience.
Sir, it is, I have used in multiple of cases, but few effects are in because medicine is good. Now the question comes in terms of posology, and I think you can agree, you do agree that it is one of what I found. It is very susceptible of tender part in our total theory. Finding out a right drug in right power and its implications, that guaranteed implications and outcome, it is very difficult, at least at my clinical practice. You are senior to me and you are sir, so you can guide us. But histamine as a medicine is good enough, but it affects some of the patient got relieved with 6, some of the patient got relieved with 3, some of the patient got relieved in 200. Now, to whom I should give 6, 3 and 200, it is, I think you are the best person to guide me.
I've been using 6 actually.
Exactly. 3 and 6 is more effective. Even arts iode 6 is also very effective. I do arts iode 6, but in the long-term treatment, arts iode in a higher dose, it is beneficial, and I got some benefits out of it.
Thank you. Thank you very much.
Thank you, sir, for your interventions and at least compensated listening. And I should be obliged for last 2-3 session of yours. It is very helpful. I have already referred in my speech as well.
Thank you very
Next
much.
is Dr. Hariharan.
Sir, your class is very nice. Scientifically, you explained the allergic disease, idiosyncrasy, but I am agree. But in my experience, I am sure that I can cure this idiosyncrasy, these allergic diseases, sneezing, rhinitis, and all by miasmatic approach. I am sure about it. See, certain medicines I will ready to say. See, arsenic is one of the best medicine for this if the symptoms agree.
Absolutely.
Natrosol in higher potency, it is very good in monsoon and gives me very good result.
Okay.
Sir, I like to say, it is the tubercular myasthenia.
Absolutely.
If you administer this tuberculinum I am giving 10 one dose intercurrently, does not repeat the sneezing or hay fever or allergic symptoms. Sometimes we must give the bacillum according to the constitution. See, we must take the constitution correctly, and if you administer in such a way also, we will get very good result. Then usually I am getting arsenic album 10 one dose. If the symptoms agree, in first instance itself, the total symptoms will disappear. In my experience, I have a lot of cases. I am curing, no doubt in that. But in latent, see, asthma cases, it is, see, first it is sneezing, then it is going to sinus as sinusitis that can be cured. But in case of asthma, see, after 10 years, if it was administered by allopathic drugs, very difficult to cure if they are administered this thing, cortisols. Otherwise, we can cure this asthma also. Sir, I have a lot of them. See, silicea. If the constitution is correct, see, if you give this silicea, it will give wonderful results. Wonderful result. See, along with that, sometimes we can give certain remedies that you said already, Aliasapa and all, but I am not going to that. You give ambrosia in hypertension, boric, ambrosia is said like that. See, another medicine is arundo. You read it, you can find the same symptoms of, see, allergic, that type of hay fever. See, certain cases we must give soranum. That will also give good result. Hay fever in boric, it is said that a soranum is a wonderful remedy. Anyway, this type of case is not a problem, though. I am sure about it. Okay, thank you very much.
Thank you, sir. Thank you for your guidance, sir.
Thank you. Next is Mr. Ahmad Hassan.
Good evening, sir. Thank you very much, sir. Very educative, especially for me. It is a good revision also, because you mentioned about the IgE and non-IgE, especially for non-eosinophilic. Regarding, sir, thank you very much for your spontaneous CSF rhinorrhea case, my wife remembrance. I would like to say, sir, here that when 3-4 days running rose not stop, then our ENT surgeon was very intelligent. Then he doubted and he told to do the specific test. I forget the name of that test, but since I was in lab, so I used the urine strip of the nasal. It is for very guidance to all our practitioners, because the nasal secretions are glucose negative, but this CSF is glucose positive. So her urine strip test came positive by the sugar, by the glucose strip. So it is very good for diagnosis to all clinicians, because to differentiate whether it is allergic rhinorrhea or it is CSF rhinorrhea, it is a very cheap test that I got during my wife disease. So that what it was confirmed. Thank you very much, sir. Thank you very much.
Thank you. Once again, Dr. Hariharan need to interact with you. Doctor?
Yes, sir.
See, last time one see Ahmad Kassan told, see, allergic rhinorrhea and this oozing of sneeze was like CSF. See, I like to say, doctor, one case I cured by this CSF oozing. That is that the medicine is arnica. I like to say that. Okay, doctor.
Sir, what was the indications for that?
Sir, long time he have a fall from a tree. That was only one symptom I got. After 10 years, rhinorrhea, CSF rhinorrhea started. Several doctors said it is difficult. See, medical college and other institutions, they said it is very difficult to cure. But simple arnica cured that case. I like to say that. Okay, thank you, sir.
Sir, dose, dose.
No, see, only 200 potency. Only 200 potency.
Okay.
Dr. Shubhajith, I need to just emphasize on thing. Here we are all talking about medicines and the therapeutic aspects of medicines. If persons here sitting here, 103 persons are here, and if they are all allowed to speak about the various medicines which we can gain effect in allergy, every person will be mentioning from their experience, and they will be endorsing that 10% they will be benefiting from some pet medicines of their own. And so, but in this scenario, we are shifting from the cardinals of homeopathy, I fear, and we need to just again point out the necessity of taking the totality and the wonder where when the whole totality is considered and prescribed, the symptoms will vanish and the allergy will be easily cured. And Dr. Shubhajith Banerji, I know you will be very proficient in this too. And I think you, on the sake of the allergy and everything in meticulously arranging on the aspects of what medicine need, you just made it like this. And here one person is also here, and only one more minute for us to conclude. And I don't know what the name is, just a Jairam Homeopathic. What the person's name I need?
Namaskar, Dr. Balachandran. This is Dr. Shubhajith Vishwas. Hello.
Please.
This is Dr. Actually, I was waiting for such kind of discussions. What you are just telling, we need to eradicate the tendency through our homeopathic treatment to the patient suffering. Actually, Dr. Banerji's information, he is very much informative, and it was wonderful, his presentation. But thing is, I do not disagree with him. In acute cases and in people used to get immediate result in few hours, in 24 hours, in 48 hours, because there is no time to wait for them. But thing is, usually in our cases, we see patients are coming from different pathies, and after many years of getting suffered from this allergic rhinitis, and usually they used to come to us to get a permanent solution. To eradicate the cases, to eradicate the situations as a whole, we need to select homeopathically selected medicine. What you are mentioning, that totality over the totality of symptoms. So I request Dr. Banerji, here is my dear senior Dr. Partha Chakraborty and all other seniors. I am very new to this platform, but I want to get some informations. So at least one case presentation, if at all possible. The time is very short, so we can get an okay now. Not if now not in coming sessions from Dr. Banerji. I want to get some case presentation that which has
sure.
been.
We will invite him again. Thank you. And the time is now reaching the limits. And so we will welcome Dr. Shubhajith Banerji again, because he's a very energetic, very promising doctor. We need you again here. And let me thank you on behalf of IFPH. And I thank you all.
Thank you.
And
Thank you.
yeah, thank you. And let's move on to the Malayalam session.
One request, Dr. Banerjee, please come again with your cured cases. Thank you very much.
Thank you, thank you. I will try, I will try.
Thank you, Dr. Banerjee. Very much, very wonderful presentation from you. Really very.
Thank you all. So over to Malayalam, Dr. Hubert De Silva.